Hello everyone, and welcome back to another video. Today we're going to talk about the various ways in the scientific medical literature where people switch from finasteride to dutasteride. As a disclaimer, this video is not medical advice. I'm simply sharing what I have done along with what other doctors have done, as well as what the scientific medical literature shows. Be sure to consult with your general practitioner and/or doctor before making any changes to your medical regimens. Also, please, like always, watch the video before asking questions. Some people don't do this and ask questions that the video already answers. So this means don't skip. If you're in a hurry, just use the timestamps. And with that being said, if you would like to support the channel, be sure to subscribe for more content and become a channel member for as little as $2 a month, or make a one-time donation on my Buy Me a Coffee link. Links are in the description, as always. Now, let's get on with the video. I've made several videos on why dutasteride is better than finasteride, all of which you can find links to in the description. The most popular study that I and others refer to would be the 2006 Olsen and colleagues clinical trial paper on dutasteride for androgenetic alopecia, titled, quote, "The importance of dual 5A reductase inhibition in the treatment of male pattern hair loss. Results of a randomized, placebo-controlled study of dutasteride versus finasteride," unquote. The study found that dutasteride significantly increased hair counts in men with androgenetic alopecia in a dose-dependent manner, with the 2.5 milligram dose showing the greatest increase. Compared to finasteride, dutasteride 2.5 milligram was superior at 12 and 24 weeks. Expert panel assessments confirmed these results, showing significantly greater improvements in hair growth for dutasteride compared to finasteride and placebo. Serum DHT levels decreased significantly with dutasteride, especially at the 0.5 milligram and 2.5 milligram doses, showing reductions of 92% and 96.4%, respectively. Scalp DHT levels were also significantly reduced in a dose-dependent manner, with the highest dose of dutasteride causing a 79% reduction. This reduction in DHT levels correlated positively with increased hair counts. The study found a significant inverse correlation between serum DHT levels and target area hair counts, meaning that lower DHT levels were associated with higher hair counts. Scalp testosterone levels increased with dutasteride treatment, reflecting the inhibition of DHT production. The 0.5 milligram and 2.5 milligram doses of dutasteride were particularly effective in suppressing scalp DHT, leading to notable increases in hair count. The correlation between reduced scalp DHT and increased hair counts underscores the importance of DHT in the pathogenesis of androgenetic alopecia. When it comes to side effects, the 2006 Olsen et al. Study found no significant differences in the overall incidence of adverse events among the treatment groups, including placebo. However, some subjects experienced decreased libido. Specifically, decreased libido was reported as follows. Placebo, 2 subjects. Dutasteride 0.05 milligram, 2 subjects. Dutasteride 0.1 milligram, 2 subjects. Dutasteride 0.5 milligram, 1 subject. Dutasteride 2.5 milligram, 9 subjects. Finasteride 5 milligram, 3 subjects. In the 2.5 milligram dutasteride group, out of the 9 subjects who experienced decreased libido, 4 saw a resolution of symptoms while still on therapy. 2 resolved symptoms within weeks after stopping therapy. 1 subject continued to experience decreased libido but deemed it unrelated to the study drug, and 2 were lost to follow-up after switching to finasteride. None of these subjects discontinued therapy due to decreased libido. This indicates that while higher doses of dutasteride are associated with a higher incidence of libido loss, the side effect was generally mild to moderate and often resolved over time. And this is very reassuring, as there are several other studies that come to a similar conclusion. For instance, the study, quote, "Comparison of clinical trials with finasteride and dutasteride," unquote, by J. Curtis Nickel, evaluates the pharmacologic effects, safety, and efficacy of these 2,5-alpha reductase inhibitors in treating benign prostatic hyperplasia. Finasteride selectively inhibits the type 2 isoenzyme, whereas dutasteride inhibits both type 1 and type 2. Clinical trials have shown that dutasteride reduces serum DHT levels significantly more than finasteride, with a mean reduction of 94.7% compared to finasteride's 70.8%. In a 12-month comparative trial, 813 patients received dutasteride and 817 received finasteride, with 719 and 735 patients completing the study respectively. Both drugs showed similar efficacy in reducing prostate volume and improving urinary flow and symptoms. The most common adverse events were sexual in nature. Decreased libido was reported in 5% of dutasteride patients and 6% of finasteride patients, while impotence was reported in 7% of dutasteride patients and 8% of finasteride patients. Generally, dutasteride appeared to have slightly fewer drug-related sexual adverse events compared to finasteride. Although dutasteride users may have a slightly lower side effect rate than finasteride users, it should be noted that due to dutasteride's half-life of approximately 5 weeks compared to finasteride's half-life of 6 to 8 hours, it may take longer for side effects to subside after discontinuation. This means side effects may persist for some weeks after stopping the medication, but they are not permanent and usually go away with continued use. In the study by Olsen et al., users of 2.5 milligram of dutasteride may experience a higher frequency of side effects compared to users of finasteride and 0.5 milligram of dutasteride. Despite dutasteride being more potent than finasteride in lowering DHT, it might have fewer side effects due to its pharmacological profile and specific action mechanisms. I would say that one possible theory is dutasteride's dual inhibition of both type 1 and type 2,5 alpha reductase enzymes allows for a more balanced reduction in DHT levels across various tissues. This dual inhibition may mitigate the localized high concentrations of DHT in tissues where finasteride, which selectively inhibits only type 2,5 alpha reductase, might cause an imbalance. Additionally, dutasteride's higher affinity and prolonged binding to the 5 alpha reductase enzymes could lead to more stable and sustained DHT suppression, reducing the hormonal fluctuations that can contribute to side effects. Another aspect to consider is the difference in their molecular structures and how they interact with other receptors and enzymes in the body. Dutasteride might have a more selective action, reducing unintended interactions that can lead to side effects. Finally, the metabolism and clearance rates of dutasteride and finasteride differ as seen in the half-life differences. These are just some soft theory explanations, so don't take this as complete fact. But I digress. We do have another study which I have talked about in depth in other videos, which is a long-term dutasteride study. The study titled, quote, Long-Term Efficacy and Safety of Dutasteride 0.5 milligram in Korean Men with Androgenetic Alopecia, 5-year data demonstrating clinical improvement with sustained efficacy, unquote, by Sungmin Choi and colleagues evaluated the long-term efficacy and safety of dutasteride 0.5 milligram in 99 Korean men aged 18 years and older with androgenetic alopecia. The participants were treated with dutasteride for at least 5 years, and their hair loss was assessed using the basic and specific classification system, a modified version of the Hamilton-Norwood scale used in South Korea, which shows the various combination patterns of androgenetic alopecia. The specific classification includes the specific V for vertex and specific F for frontal types. This study also used the Investigator Global Assessment 7-point scale. The results showed that 89.9% of patients experienced clinical improvement and 93.9% showed prevention of hair loss progression. Improvement was most notable in patients with the specific V for vertex type of hair loss, with 82.2% showing clinical improvement. The study concluded that dutasteride 0.5 milligram is highly effective in improving hair growth and preventing the progression of androgenetic alopecia over a long-term period of at least 5 years, with sustained clinical efficacy and a favorable safety profile. So with this kind of information, it's no wonder why people may want to switch from finasteride to dutasteride, or at the very least implement dutasteride in some way in their hair loss regimen. Now, this isn't to say that finasteride doesn't work or isn't effective. We do have studies that show its long-term success too, such as the 10-year Japanese study and 10-year Italian study. However, some people do lose ground and have very aggressive hair loss at young ages. Dutasteride use in some way, shape, or form may be enough to help those individuals. In the next sections or videos, depending on how I cut things up, we will explore the various implementations of dutasteride as well as transitions. I'll also include what I did. Remember, talk to your doctor and do not self-medicate. Now, I've talked in previous videos about actively exploring the literature on transitioning from finasteride to dutasteride. During my research, I found a study discussing the implementation of loading phases to reach a steady-state concentration of dutasteride in the bloodstream. A steady-state concentration is important because it ensures that the drug maintains a consistent level in the body, which is crucial for its effectiveness. This consistency helps in maximizing the therapeutic benefits of the medication while minimizing fluctuations that could lead to side effects or reduced efficacy. Reaching a steady state concentration means that the rate of drug administration equals the rate of drug elimination, leading to optimal and stable treatment outcomes. I'm going to need you to pay close attention to this part because I think the previous video may have confused some people, and admittedly, I could have explained it better. So, serum concentrations of DHT have been observed to decrease in short order on a 0.5 mg per day use. The study titled, quote, Effect of Dutasteride on Intraprostatic Androgen Levels in Men with Benign Prostatic Hyperplasia or Prostate Cancer, unquote, by Roger Rittmaster and colleagues investigated the effects of dutasteride on serum and intraprostatic DHT and testosterone levels. The study included 300 men with benign prostatic hyperplasia or prostate cancer who were treated with dutasteride, 0.5 mg daily, for periods ranging from 2 weeks to 4 months. The results showed that dutasteride significantly reduced serum DHT levels by 83.5% after 2 weeks and by approximately 90% after 1 to 4 months compared to the control group. Prostate tissue. DHT levels were reduced by 83% after 2 weeks and by 90% to 93% after 1 to 4 months of treatment. The study concluded that dutasteride provides near maximal suppression of both serum and intraprostatic DHT levels within a short period, maintaining this suppression throughout the treatment duration. So we know that serum DHT decreases after 1 to 2 weeks of use by nearly 80% while using dutasteride at a 0.5 mg daily use. And when it comes to prostate tissue, DHT there is also reduced by the same percent in a similar time period. However, we don't have any studies regarding how long it takes for the scalp tissue suppression to be observed and reflected in the hair follicles. What we do have is the investigator checkpoints. And for a quick explanation, investigator checkpoints are just points in a study where researchers establish when they will check on a subject to observe if some kind of change has occurred in said subject. It is plausible to argue that scalp DHT levels might take longer to reflect these changes compared to prostate tissue DHT levels. Also, might I remind you, the men in the study, quote, Effect of dutasteride on intraprostatic androgen levels in men with benign prostatic hyperplasia or prostate cancer, unquote, by Roger Rittmaster and colleagues have prostate tissue cells that have been altered as they had either BPH or prostate cancer. The scalp and prostate have different physiological environments and enzyme activities. For instance, the expression and activity of 5-alpha reductase, the enzyme responsible for converting testosterone to DHT, varies between these tissues. This enzyme exists in 2 isoforms, type 1 and type 2, which have different distributions and activity levels in the scalp and prostate. We can get a quick and better understanding by referring to this paper titled, quote, Medical Aspects of the Treatment of Lower Urinary Tract Symptoms, Benign Prostatic Hyperplasia, 5-alpha reductase inhibitors, unquote, by Jamie A. Cavallo and Stephen A. Kaplan. In the context of benign prostatic hyperplasia and prostate cancer, The physiological environment and enzyme activities in the prostate are notably different from those in the scalp and normal prostate tissue. Jami A. Cavallo and Stephen A. Kaplan summarizes that the enzyme 5-alpha reductase exists in two isoforms with distinct distributions and functions in various tissues. In the prostate, 5-alpha reductase type 2 is more abundant and predominantly expressed in the cytosol of stromal and basal prostate cells. In contrast, 5-alpha reductase type 1 is primarily found in the nucleus of prostate epithelial cells. This differential expression plays a critical role in the pathophysiology of benign prostatic hyperplasia and prostate cancer. In benign prostatic hyperplasia, there is an overexpression of both 5-alpha reductase type 2 and type 1 with a higher concentration of type 2. This overexpression is associated with the proliferation of benign smooth muscle and epithelial cells within the prostatic transition zone, contributing to the disease's clinical manifestations. In prostate cancer cells, however, there is increased expression of 5-alpha reductase type 1 and decreased expression of type 2 compared to benign and benign prostatic hyperplasia cells. This variation in enzyme expression is particularly pronounced in high-grade localized prostate cancer, where both isoforms are elevated compared to low-grade cancer. Dutastride's pharmacokinetics and pharmacodynamics allow it to effectively target these overexpressed enzymes. Dutasteride has a high affinity for both 5-alpha reductase types 1 and 2, enabling it to efficiently reduce DHT levels in the prostate. The overexpression of these enzymes in benign prostatic hyperplasia and prostate cancer tissues creates an environment where dutasteride can be rapidly absorbed and exert its effects more efficiently compared to normal prostate tissue or the scalp. This rapid absorption and effectiveness in reducing intraprostatic DHT levels can be attributed to the drug's ability to bind strongly to the abundant enzyme targets present in these pathological conditions. So in other words, we can't say this reduction in DHT levels would be similar across all tissues, especially in the scalp. That would be inappropriate. Unless we get better studies on the matter, I would argue that changes in the scalp tissue DHT environment would take longer than the changes in prostate tissue, especially prostate tissue that has cancer or benign prostatic hyperplasia. And I just want to note this. While a reduction in serum DHT can suggest that treatments like finasteride or dutasteride are having an effect, it's important to understand that this doesn't fully reflect the reduction of DHT within tissues where these drugs are primarily intended to act. This discrepancy arises because these medications target the enzyme 5-alpha reductase specifically in tissues that are rich in this enzyme, such as the prostate and hair follicles. The primary action of these drugs is to prevent the conversion of testosterone to DHT right at the site where this process normally happens, which significantly impacts tissue DHT levels, but may not correspondingly influence serum DHT levels to the same extent. The serum contains only a small fraction of the body's total DHT, as well as a lower concentration of circulating 5-alpha reductase enzymes compared to that which is in the tissues like the skin and prostate. Circulating levels of DHT are observed to be 1/10 and 1/20 those of testosterone in terms of total and free concentrations, according to Basin S. book titled, quote, Pharmacology, Biology, and Clinical Applications of Androgens, Current Status, and Future Prospects, respectively, unquote, on page 72, whereas DHT levels in the skin may be up to 10 times those of testosterone in tissues with high 5-alpha reductase expression, such as the prostate gland and skin tissues, as noted in by Hay and Wass's 2009 excerpt in Clinical Endocrine Oncology on page 37. Therefore, serum measurements can underestimate the drug's efficacy in tissues where DHT's reduction is crucial for therapeutic outcomes. For example, in treating conditions like prostate enlargement or androgenetic alopecia, the critical factor is the extent of DHT inhibition within the prostate or the scalp, respectively, rather than in the bloodstream. This localized reduction in DHT can lead to the desired effects, such as decreased prostate size or slowed hair loss, even if serum levels of DHT show only modest decreases. Also, serum DHT is mostly bound to sex hormone-binding globulin, also called SHBG, when in the bloodstream. SHBG helps modulate sex hormone levels in men and women by binding to androgens and estrogens. This makes a particular ratio of these hormones inactive at any given point. When they are inactive, these hormones can't readily be used in metabolic processes unless something happens to remove SHBG from them, according to Ronald S. Swerdloff and colleagues in their paper titled, quote, Dihydrotestosterone Biochemistry, Physiology, and Clinical Implications of Elevated Blood Levels, unquote. This makes the DHT in serum largely inactive. This means it can't do much to either grow your prostate, grow your muscles, or finally mess up your hair follicles. Once again, we are only concerned about DHT in the tissues because that's where it is mostly produced, not in the blood. Additionally, the dynamics of DHT production and regulation vary between different tissues, influenced by factors like local enzyme concentration, tissue-specific expression, and the presence of other cofactors affecting enzyme activity. This complexity means that even if a drug effectively reduces DHT levels in one type of tissue, such as the prostate, its impact on other tissues, and by extension on serum levels, might be less pronounced. Hence, while a decrease in serum DHT is a positive sign that finasteride or dutasteride are working, the true measure of effectiveness, particularly for localized conditions, is better assessed by considering the reduction of DHT within the target tissues themselves. One potential argument I can think of would be based on the difference in blood flow and tissue permeability between the scalp and prostate. I would argue, and I could be wrong here, but a key factor is the difference in vascularization between the scalp and the prostate. This could explain why DHT levels in the prostate drop more rapidly following oral dutasteride administration, at least what we know about in men with BPH and prostate cancer cells. The scalp's blood supply, while rich, is more diffusely distributed and involves a more intricate network of capillaries. The scalp receives blood from multiple branches of the external carotid artery, providing extensive coverage to the skin and hair follicles. This diffuse nature of blood flow might contribute to a slower and more complex process for drugs like dutasteride to reach and maintain effective concentrations within scalp tissues. In contrast, the prostate's blood supply is more direct and concentrated. The prostate receives blood primarily from the inferior vesical arteries, with venous drainage through the prostatic venous plexus, which efficiently supplies the organ with nutrients and drugs. This structured vascularization might allow dutasteride to achieve and maintain therapeutic levels more rapidly and consistently in the prostate compared to the scalp. When reading the Merck Pharmaceutical Company manual website, the article titled Drug Distribution to Tissues by PharmD Jennifer Lam states that the rate at which a drug enters a tissue is influenced by blood flow to the tissue, tissue mass, and the partition characteristics between blood and tissue. Distribution equilibrium, where the rates of drug entry and exit are equal, is reached more quickly in richly vascularized areas unless membrane diffusion is the limiting step. Membrane diffusion is the process by which molecules move from an area of higher concentration to an area of lower concentration across a cell membrane. The prostate, especially when enlarged due to benign prostatic hyperplasia or affected by prostate cancer, generally has a more extensive vascular network compared to the scalp. Also, the concentration of blood flow to the tissue is much more compact. With the anatomy of the scalp, keep in mind, although it is fairly vascularized, the blood flow is spread throughout the scalp with many vessels and a more intricate network of capillaries. This would make a drug like dutasteride fairly diffuse throughout the scalp tissue. This means that drugs like dutasteride are more rapidly absorbed and distributed in the prostate tissue than in the scalp. The relatively high blood flow in the prostate ensures quicker delivery and a higher concentration of the drug in the tissue, leading to more efficient suppression of DHT levels. Of course, this is just my research and understanding. If you have a different opinion, I would welcome the discussion. So with all this in mind, it makes sense why investigators in the Olsen et al. Study would wait 12 weeks and 24 weeks for their checkpoint assessment on things like hair count and scalp DHT. I don't think with the present evidence that we can conclude that scalp DHT levels would drop similarly to prostate tissue DHT levels in the same time period. Also, serum reductions in DHT is not the same as tissue, as DHT is a paracrine hormone, and levels in the tissue are way higher and much more compact than in the blood and/or serum. Also, as a side note, it is known that men who have androgenetic alopecia have a higher density of 5-alpha reductase around the hair follicles than men who don't have androgenetic alopecia. It would even stand to reason that the more severe one's androgenetic alopecia is, the higher the 5-alpha reductase enzyme concentration and possibly androgen receptor sensitivity. For a quick summary understanding, the article titled, quote, "The Hormonal Background of Hair Loss in Non-Scarring Alopecias," unquote, by Barbara Oweka et al., discusses this when referring to androgenetic alopecia. They explore the literature to state that men and even women who have androgenetic alopecia have upregulated DHT levels in their hair follicles. At least in the case of high 5-alpha reductase concentration, I could see the argument of dutasteride being more effective for such men. A greater density of 5-alpha reductase enzymes in a tissue would mean a higher affinity for that tissue to dutasteride. Dutasteride works by inhibiting the 5-alpha reductase enzymes, which convert testosterone to dihydrotestosterone, DHT. If a tissue has a higher density of these enzymes, more binding sites are available for dutasteride to attach to, leading to a more pronounced effect in reducing DHT levels in that tissue. This is particularly relevant in tissues like the prostate, where both types of 5-alpha reductase, type 1 and type 2, are overexpressed, making it highly responsive to dutasteride treatment. So people with higher 5-AR concentrations around the hair follicle might have worse androgenetic alopecia occurring earlier in life. Also something to add on. According to the paper titled, quote, "Use of 5-alpha reductase inhibitors in dermatology, a narrative review," unquote, by Mariana Escamilla Cruz et al., dutasteride provides roughly 3-fold higher inhibition of type 2,5-alpha reductase compared to finasteride and 100 times stronger inhibition for the type 1,5-alpha reductase enzyme. Dutasteride also has a very slow dissociation to 5-alpha reductase enzymes, according to the Avodart dutasteride FDA paper, where it directly states this. This high affinity for 5-alpha reductase enzymes, along with a slow dissociation, makes dutasteride very good at preventing the conversion of testosterone to DHT. Therefore, in my opinion, dutasteride would be more effective. Like everyone else, I started using finasteride at 1 milligram a day for 1.5 years. Wanting to get more DHT suppression on the scalp, I eventually thought about implementing dutasteride in my hair loss stack in some way. From the advice of my dermatologist and endocrinologist, as well as my own personal research in the scientific medical literature, I started my transition from finasteride to dutasteride by using a 6-day 1-day approach, then moving to a 5-day 2-day approach. So what does this mean? For 6 days I took 1 milligram of finasteride, and then on a single day I took 0.5 milligrams of dutasteride each week. After a month, I increased the frequency of my dutasteride use while reducing my finasteride use. This transition to taking 1 milligram of finasteride for 5 days, typically Monday through Friday, and then 0.5 milligrams of dutasteride on the weekends, Saturday and Sunday. The idea here, over time, as the months go by, one more 0.5 milligram dutasteride capsule is added into the week, while one 1 milligram finasteride tablet is decreased throughout the week. This goes on until dutasteride is taken for 7 days, so ideally, this transition could be done within 7 months. Don't ask me about the specifics of your case, as I won't answer. Talk to your doctor and do your own research. Najwa Somani and Marty E. Sawaya, in their paper titled Anti-Androgens and Androgen Inhibitors, provide an overview of several dutasteride transition protocols found in the literature. One protocol involves dosing at 0.5 milligram daily in men who fail or have an inadequate response to finasteride. A study by Jung J.Y. et al. Titled Effect of dutasteride 0.5 mg per day in men with androgenetic alopecia recalcitrant to finasteride, involving 31 South Korean men for whom finasteride was ineffective, showed that 77% of these men had improved hair density with a switch to dutasteride 0.5 mg daily. Another protocol involves dosing at 0.5 mg daily for 2 weeks, loading, followed by 0.5 mg twice weekly thereafter, as demonstrated in a paper by Rogers and Avram titled Medical Treatments for Male and Female Pattern Hair Loss. Finally, a paper by Ann Boyapati and Rodney Sinclair titled Combination Therapy with Finasteride and Low-Dose Dutasteride in the Treatment of Androgenetic Alopecia describes a case study of a 47-year-old man for whom finasteride seemed to be losing efficacy after 4 years. The researchers added dutasteride at 0.5 mg once per week to daily finasteride therapy, which improved the subject's hair in a very short time. Now, there's a question of whether a 2.5 mg dose of dutasteride is more effective compared to a 0.5 mg daily dose. The Olsen et al. Study shows that the 2.5 mg dutasteride treatment group had a superior hair count compared to those in the finasteride and various dutasteride treatment groups. One argument is that the reason for this could be that a 2.5 mg dose per day of dutasteride reaches steady state concentration much sooner than the typical 0.5 mg daily dose. Thus, it could be the case that the reductions in scalp DHT occurred sooner, allowing the hairs to shed and go through a better regrowth cycle. In other words, perhaps with a long enough treatment period, scalp DHT levels may be equivalent between 0.5 mg and 2.5 mg dutasteride users, with the decrease occurring sooner in 2.5 mg dutasteride users, leading to earlier positive changes in hair counts. The Olsen et al. Study only lasted for 24 weeks, so we really can't say for sure. However, at the 12-week and 24-week marks in the study, the changes in scalp DHT were significant, suggesting that 2.5 mg of dutasteride may at least push you through the shedding phase quicker. At most, we could conclude that the differences in scalp DHT between the dutasteride treatment groups are due to its load and presence in the tissue. This means that for the average user, it would be harder to achieve an 80% decrease in scalp DHT with a 0.5 mg per day dose of dutasteride than with a 2.5 mg per day dose. So that's pretty much it for this video. The choice between finasteride and dutasteride should be based on individual needs and responses. Considering the differences in effectiveness, side effects, and personal circumstances, I hope my reasoning is clear and somewhat grounded in the current understanding of medical science. If you would like to support the channel, subscribe and consider becoming a member for as little as $2 a month. Links, as always, are in the description of the video. And if you've made it this far into the video, comment "hair science enthusiast" to let me know you're a dedicated viewer.